each of the 4 valves can become diseased. Those valves can either have failure to open properly, which is called stenosis, or the valves don't come together well and the valve leaks, and that's called regurgitation. Which means if there's regurgitation, then the right atrium, if the tricuspid valve is leaking open, the right atrium is experiencing the blood pressure of the right ventricle. Which means the venous pressure is going down the inferior vena cava. Which means if the venous pressure is greater than 10, then water is leaking out of the venous side of the capillary and causing ascites. And when it goes down the leg, it's causing edema. And then if you have the same process where the left atrial pressure is increased, that pressure goes to the lungs, the water leaks out of the lungs, causing pulmonary edema or a pleural effusion. Or both, usually, okay? So hopefully just in that brief description, you can understand why fluid backs up, blood, water leaks out of the tissue, and we get edema, wherever it might be, in the brain, in the lungs, in the legs, and in the abdomen, all right? So conceptualize what each of these valves does, and then what happens behind it. And then, if it's pathology on the right side of the heart, how does that affect the left side of the heart? So let's take another example. Let's say we have bad tricuspid regurgitation. So the heart, as a muscle, responds in one of 2 ways to pressure changes. When pressure is due to increased volume, what does a chamber have to do to manage that volume?
Squeeze harder.
It has to get bigger. Okay? So the right ventricle starts to dilate. On the other hand, if a valve is stenotic, the pulmonary valve, for example, on the right side of the heart, and volume is okay, what does a ventricle have to do to get that same amount of volume out through a tight valve?
Squeeze harder.
Squeeze harder. So what happens to that ventricle? It gets thicker. And then what happens to that ventricle when the muscle gets thick? It has less diastolic compliance. All right? So the pathology is understandable if you know what the anatomy is of the valve. Okay? And that's valve pathology, stenosis versus regurgitation. What has happened to the ventricle? Is it big and like a balloon? Or is it a real thick ventricle that's got a little tiny chamber? All right? And if you understand that physiology, you can better learn how to treat it. All right? Okay. Then we have one more component to add to the valve and how that affects the muscle, and that's if the muscle is getting enough blood supply. Okay? And when the coronary arteries have an impact on the muscle gets weak, the muscle doesn't squeeze as well, and then you're right back to that same problem of volume. Okay? Volume's not being pushed out because the ventricle is dead. So then the ventricle starts to dilate to compensate for the increased volume. What is important in particular with the left ventricle in terms of squeeze and its shape? Okay? The shape of the ventricle is a cone, all right? It's not a sphere. And what's the difference? The cone squeezes like this, so that blood's going this way, but it's also going this way from the apex. This chamber does not have this gets like this when the sarcomeres get stretched out. And pressure becomes equal in all directions in the chamber. That's not the case when the ventricle is shaped like a cone. That's why the cones can still squeeze very well from the bottom. But there's one other component to ventricular contraction, and it's a ringing motion, okay? The ventricle is shaped like a cone for a reason, because it's not just going like this, it's going like a washing machine. And that improves ventricular function. But when the ventricle is shaped like a sphere, the ringing motion goes away. Okay? That is a super important component to ventricular function, is the ringing motion. Probably not more important, but a ventricle that doesn't have a ringing motion is going to have depressed function. Okay? And that's a super important aspect to understand in patients who have coronary artery disease and a dead wall due to a blocked artery. Okay, so let's talk about the coronary arteries for a minute.
Would that what you just described example of Takasubo's though too?
So Takasubo's is an unclear etiology to decreased ventricular function. It hurts, but it also causes heart failure. Okay. Why that exactly occurs, I don't think we understand that. That is probably more of a neurohormonal problem than we give credit. It's not a coronary artery problem because the coronaries are normal by definition.
But the shape of it looks different. That's why they call it Takasubo's, and that's
and
kind
it's
of
spherical.
Way.
But that's.
I mean, it happens.
Was it that way before, or is it a result of the event that occurred?
Yeah.
But it's a spherical shape. Yeah.
Okay.
Does that shape just apply to the left ventricle? Or
No, it definitely applies to the right ventricle too. When we look at an echo, it looks like this, right? That's why a heart is what it is, okay? It doesn't look like this, okay? It's two cones, yeah. Okay, the coronary arteries. Did Mark go through anatomy?
We did. We've
You
gone
did.
through the anatomy.
Okay,
of the
so
coronary
everybody
arteries.
knows what the LAD is
Mhm.
and the circumflex. So we have three main arteries that feed blood to the heart muscle. The left main coronary artery is a short artery. Okay, so the left ventricle ejects oxygenated blood out the aorta to our body. What are the first two branches of the aorta?
Left main. And then
The left main coronary artery
I see.
and the right coronary artery.
Okay.
Okay?
You were talking about
So,
off the aorta.
they are-
I'm like, what are you talking about? That?
The aortic valve is a three-cusp valve, normally. Actually, the aortic valve is the most common birth anomaly, where instead of a three-cusp valve, we have a two-cusp valve, called a bicuspid valve. 5% of the population, boy, you get going on a roll. 5% of the population has a bicuspid aortic valve. These are good valves. Because of the 5% of the whole population, only 15% of them ever need an operation. So now, when does that operation occur? Oop, not quite. It occurs at two different points in our life. At age less than 2 and age greater than 50.
Oh, my husband's getting close.
So,
Turns
these
50 this year.
these bicuspid valves are good valves,
He does.
okay? If any of you have a bicuspid valve, don't think that they're necessarily bad, all right? If you got through your first 5 years of life, that's a good aortic valve, and it's gonna last you a long time. Okay, we got distracted. But 95% of us have a three-cusp aortic valve. And the left main coronary artery and the right coronary artery are the two arteries that feed blood to the heart muscle. And the left main coronary artery comes off and it goes behind the pulmonary artery to the front of the heart, and then it splits into the LAD and the left circumflex. And the right coronary artery comes over the top of the heart and goes to the right side of the heart, down to the bottom. Okay? The right coronary artery. And our coronary arteries are prone to atherosclerosis, hardening the arteries, fat, cholesterol, whatever term you want. And when we cut these arteries in half, you see this layering upon layering upon layering until the vessel closes, and that's a heart attack, okay? When oxygenated blood is interrupted to the tissue and the tissue dies, myocardial infarction, okay? That's coronary artery disease. And it can happen anywhere in the system, but comorbidities increase the incidence of coronary artery disease and where that coronary artery disease occurs. So, diabetics. Diabetes affects our medium and small sized blood vessels. That's why diabetics get strokes. That's why they lose toes, and that's why they lose kidneys. It's not because the diabetes affects the aorta where the blood comes off to go to the kidney. It does. But where it's really having an impact is at the capillary level. And the arteries get filled up with atherosclerosis, and oxygenated blood supply gets terminated, and the kidney dies. Okay? Same with the coronary arteries. When these coronary arteries come around and they start branching and getting smaller and smaller and smaller, diabetics get diffuse disease that starts out in the small arteries first and works its way back. Okay? On the other hand, smokers, nicotine has a greater impact in the larger arteries, and that's why smokers get aorta disease, like in their belly. They get aneurysmal disease. They get carotid disease, the big arteries going to the brain. And they also get disease more proximally in the coronary arteries, like in the left main coronary artery, or in the proximal aspect of the LAD. And when those arteries go down, these are arteries that are very proximal on the big ventricle, and it has a greater impact on how much injury occurs to the muscle. Okay? So, for example, about the LAD supports about 65% of the left ventricle. Okay? The left circumflex supports about 20% of the left ventricle, and the distal branch of the right coronary artery, called the PDA, affects 15. Does that get us there? Something like that. What does the LAD supply? The LAD supplies the septum, okay, the big thick septum, and the whole anterior wall of the heart. And when the LAD goes down, or the left main goes down, that is a myocardial infarction that has a higher rate of fatality. If the lesion is truly a left main, what's that called? Widowmaker, okay? And that's why it's called the widowmaker, because they die at home, in bed, all right? And yeah, so that's kind of the hallmark of coronary artery disease, is a tight left main. And to that point, we typically don't wait on left mains. We either operate on them the same day if their symptoms persist, or if we can get them to quiet down, we'll operate on them the next day. But we don't send left mains home. The legacy rule is you don't let the sun rise or the sun set on a left main. Okay? So if they come in at night, you don't let the sun rise. If they come in during the day, you don't let the sun set. That's what that means. Okay? So, coronary artery disease, if the circumflex goes down and the patient has a big lateral wall myocardial infarction, then ventricular squeeze starts to deteriorate. The lateral wall is now dead and not squeezing, and what does it do? It starts looking like that. Take 403. 403 came in with a lateral wall myocardial infarction by EKG. We took him to the cath lab, we injected his left main, and guess what he had? He had a high occlusion of the entire LAD and never experienced a heart attack. He had a wide open right But very importantly, if you don't know what he had a 99% occlusion in the circumflex.
Oh, cool.
Okay? He was living on his right, which really does not have very good supply to the septum or the anterior wall. But it has good supply to the lateral wall. So even though this was a high-grade lesion, this was keeping him alive. Okay? His right was keeping him alive. And Dr. Magatsky attempted to open his LAD, tried to get a wire through it, and it was chronic, couldn't get a wire through it. So there was no intervention to do on the LAD. But the circ was super easy. Wire went right through, ballooned it open, he got 2 stents, and his hemodynamics stabilized immediately. So what does that tell you? Remarkably, it tells us that his ventricle was very dependent on that LAD, or on that circumflex. It was being kept alive by his right, but he didn't even realize he'd had a heart attack due to an occluded LAD. So now the question is, to close the loop on 403, is there muscle that typically would be supported by the LAD that's still alive in the anterior wall and septum? And the way we want to evaluate that, because if there is, because his ejection fraction, even after opening this, is still only 14%. That's going to be a miserable quality of life for him, because the ventricle is going like that, because the lateral wall is because the anterior wall is already dead, and the lateral wall has already had some degree of injury. Okay? And he's going to go into heart failure long term. But the question is this anterior wall viable? And we'll evaluate that by MRI and see if there's viability. And if there is, then we'll go in and we'll do a single vessel bypass to his LAD, okay, and restore circulation to the anterior wall and septum. And hopefully he'll have some viability. But
48.
I don't think he's going to, because his ventricle is already dilated. When we cut across the muscle, we see that he's got, the muscle has gotten all thinned out in the anterior wall. So this is looking from the esophagus out. The anterior wall and lateral wall are thinned, and the distal part of his septum has gotten all thinned out, because it's not muscle anymore, it's just a bag. Okay, let's talk about what is the ideal heart rate. Okay, so the more important question is, what is,
say 80, say 80.
what is the ideal stroke volume? What comprises cardiac output?
Heart rate times
Heart rate,
volume.
stroke volume, 60 to 100.
I know SVI.
Okay. What is the guiding principle? Well, there's kind of 2 guiding principles on stroke volume. One is the squeeze, okay, but what's the other? It's the fill.
Fill.
Preload,
Okay.
afterload, and contract.
That is the key, is the fill, all right? And that's what we can help to control with heart rate. If you pace a patient at 100, there's not enough time in the cardiac cycle for the ventricle to relax and fill. If you pace the ventricle at 60, then the ventricle's in diastole for too long and it's not ejecting the blood. So, we can have some impact on stroke volume with preload and with chronotropy, or with inotropy. But the other way to control cardiac output is with heart rate. So then the question is, what's the ideal heart rate? And for most of our patients, that ideal heart rate is 80. Okay? That gives us the most cardiac output, maximizing efficiency of relaxation and squeeze. Okay, so that being the case, that's the ideal heart rate for maximum oxygen consumption. That is, if your heart rate's 100 and your ventricle's not relaxing, it's not getting a full stroke volume, that's not efficient squeeze. You're using too much oxygen. If the heart rate is 60, the ventricle's just sitting there for too long and it's not maximizing the oxygen that it's getting. So the ideal heart rate is 80. except in a thick ventricle, okay? Then you want it to be slower because you need more filling time. So then you gotta think about what causes a thick ventricle. Well, aortic stenosis, but also diseases of the ventricle like amyloid, hypertrophy, asymmetric septal hypertrophy, hypertrophic obstructive cardiomyopathy, HOCM, but now that term that's being used globally is just hypertrophic cardiomyopathy, okay? And that's a bulge, a thickening of the, specifically to ventricular outflow, a bulge in the septum that causes obstruction to left ventricular outflow, all right? It does some things to the mitral valve, which is actually the causative agent of obstruction because it pulls the anterior leaflet of the mitral valve over in front of the aortic valve. That's what causes the obstruction. It's not actually the bulging muscle itself, but it's the turbulent flow that sucks. It's the turbulent flow going around the thick septum that pulls the anterior leaflet over, okay? The Venturi effect. So there's things that, and the most common thing that decreases ventricular outflow is hypertension. Okay, hypertension that causes the muscle to get thick. So all of those things got to be considered when you're talking about your chronotropy, your inotropy, your vasodilation, etc. So all of our patients come back to the ICU with a heart rate of 80. All right, I don't see a pacemaker.
It's in a room.
Yeah.
We will learn how to do pacemakers. We AV pace 100% unless the patient has an adequate atrial rate, and then you can A-sense and V-pace. Or if the patient's in AFib, don't A-sense, because the pacemaker can't differentiate AFib from a sinus rhythm. And that's what happens when you hook up your pacemaker, AV, and your ventricular rate now is 180. Okay, that's because you're A-sensing in a patient who's in AFib, and you're effectively causing AFib with rapid ventricular response. That's the patient where you turn the A off and you just V pace at 80. And if their heart rate is above 80, then the ventricle will go faster than 80. If it's less than 80, like 60, because there's incomplete conduction, then at least you'll have the ventricle squeezing at the ideal rate of 80. Okay? So pacing. We AV pace until we prove otherwise. Now, you will see there are surgeon ways to test the pacemaker, and there are ways that you're supposed to test the pacemaker. Okay? Do not just pull the cable out of the slot. Turn the rate down until you know what the underlying rate is. Okay? We do not advocate disconnecting the pacemaker. We don't practice what we preach. We walk in there, we grab the pacemaker, we yank that V lead out, and everybody looks at the monitor and it's asystole. And then you're like, oh my gosh, you gotta get that thing back in there. Okay? You guys should not do that. Don't do that. Okay? Turn your rate down. Okay? It's okay if you want to see what's under the atrial pacing wire, take the atrial lead out. I'm okay with that. Okay? The other thing you can do is just unlock it and turn your atrial milliamps down until you lose capture. And then you can see what the atrium is doing. But it's all about the V wire. You guys should not pull the V wire out of the pacemaker. Okay? All right. And the ideal rate is 80. Chest tubes. Almost to the last thing. Mark may have already gone through this with you. It's a pretty easy protocol for blood loss. What is worrisome blood loss? Does anybody know?
Greater than 200 2 hours.
All right, so your top one's 1,000. This is the
Over an hour.
There you
1,000.
go. So,
500.
This is
1,000 in the first hour, 500 in the second hour, 200 an hour
For 4 hours.
for 4 hours. Okay.
This is for 4 consecutive rounds, right? 200 each.
And then 10 hours is 100 cc's per hour. Okay? This is the one, though, that none of us are following anymore. A liter of blood loss is a lot of blood loss. That is surgical blood loss, okay? That is not a coagulopathy. That's a patient that needs to go back to the operating room. All three of us are on board on that today. We will take a patient back to the operating room for 1,000 cc's an hour. We will be very concerned about a patient who puts out 500 cc's an hour for 2 hours. 200 cc's an hour for 4 hours. It's in the back of our mind, but we're still working on the coagulation cascade, okay? We're trying to convince ourselves that it's not surgical, all right? And hopefully we can get it. But those are the things to remember. If you put out 500 cc's in an hour at any time, we need to know about that, okay? And but for guidance, if it's 500 cc's an hour for 2 hours and you haven't heard from us, we need a phone call, okay? Especially today, because we have such an aggressive blood conservation program. We will take that patient back to the operating room way more quickly now than we did 15 years ago, okay? So those are those numbers, those are easy. Extubation protocol.
So do you want us to call you and tell you that the patient's dumping?
There you go. That's another, that is a bad word, okay? If you want to rile us up, you can use the word dumping, okay? The chest tubes are dumping. I just want you to know that how much the chest tubes are dumping. Then you take a deep breath and you go, well, how much are the chest tubes dumping? Well, the patient had 30 cc's in the last hour. That is not dumping, okay? That is not dumping. Yeah, dumping's a bad word, okay.
Unless it really is dumping then, right?
Well, unless you're really trying to stick it to us, then you can say, then if you say 500 cc's, then we're like, oh, geez.
You're not even worried.
Cat's out of the bag. Dumping
Just
is
go
a
for
bad
the
word.
objective terms.
Okay,
This is how
extubation
much I'll
protocol. So, the STS has an extubation protocol at less than 24 hours, okay? Prolonged ventilation to the STS is greater than 24 hours. Back in the day, 100% of patients did not get extubated until the next day. They sat on the vent, paralyzed and sedated all night. You turn the paralytic off at 4 o'clock, you turn the sedation off at 6 or 7 o'clock, you tried to get them extubated the next morning, and then you hope that you could get them out of the ICU, the next afternoon. Our system has a 7-hour protocol, okay, for open heart surgery. And Utah Valley has a 4-hour protocol, all right? We want the vast majority of our patients extubated at less than 4 hours to meet our protocol, okay? But it's not a measurement to the STS for 24 hours, okay?
I can't give it life.
I know.
For the last 5 years.
Okay. So, you guys manage extubation, you and the respiratory therapist, okay? Our goal, conceptually, is to get the patient extubated before they remember the tube, okay? That causes more PSD in heart surgery patients than just about anything, even more than CPR, okay? Probably the one thing that causes more PTSD in the heart patient is getting shocked and not being sedated. Okay, that's a big whack. But having a breathing tube in place and not being able to get that tube out, that causes more PSTD in our patients than just about anything, PTSD. And so we want the patient extubated before they're awake enough to realize they have a tube in there. So we do not titrate propofol, okay? Our goal is to get that tube out before the patient is completely awake, but they gotta be breathing strongly on their own. They gotta have adequate strength. So unless the patient is a respiratorily compromised patient for smoking, COPD, emphysema, pneumonia, whatever the cause may be, If the patient can lift their head and they can answer questions and the FiO2 is at 40% and they're on CPAP, we extubate them. Okay? We don't go through the whole negative inspiratory force and all that jazz. The respiratory therapists do, but we will often just walk in and say, hey, can you lift your head? They lift their head, they're on 30%, and they're on CPAP, we say extubate them, okay? And because they've only been asleep for 6 hours, they haven't been on the, remember, they have not been on a vent for even a day, okay? These are not patients that have laryngeal swelling. These are not patients that have cooked lungs already. They're not COVID patients. They don't need to meet what is really a pretty vigorous extubation protocol. They need strength and they need decreased oxygen. And then, even when you extubate them, we'll slap people on CPAP at 50%, no problem, okay? Just to get them extubated, all right? So, how do we manage the propofol? We don't use Precedex, okay? We tried. Precedex did not work for us. If you go to St. George, they extubate all their patients on Precedex, keep them on it for 24 hours. It didn't work for us. And that's a pretty common theme, it seems to be. You know, it works in some places, it doesn't in others. We use propofol. When you're ready to extubate, you've got the neckline done, the chest x-ray is done, the EKG, the patient is settled. Half the propofol for 15 minutes. And then after 15 minutes, turn it off, okay? Propofol is not a titratable sedation medication, okay? At least not when they've only been on it for literally an hour or 2 hours after heart surgery. It is not titratable. They either need to be asleep or they need to be awake. And then when they're awake, extubate them, okay? And put them on CPAP. We'll get the vast majority through it. Okay, I have a experience not too long ago where I instructed to extubate a patient and we had to reintubate the patient, and there was a lot of unhappiness about it, and I understand that, but that's one in the last 500. Okay, it happens occasionally. If you are concerned, call us. Okay, we want those patients extubated before 4 hours. They do better. Your drip requirements are less. The patients are less demanding. They feel better more quickly. Okay, they don't get as much swelling. They don't have sore throats. They can eat sooner. So there are positive reasons for getting the patient extubated. 15, get your work done. Decrease propofol for 15 minutes. Turn it off. If they're fighting you, get the tube out, okay? Get the tube out. They'll stop fighting, all right? These are patients that are hemodynamically stable. They're doing well. They're not bleeding, okay? But if all those parameters are met and the patient is fighting you when they wake up, it's because of the tube, all right? So extubate them. And we kind of know who the therapists are that are positive and the ones that maybe are less so. We see a lot of Chris, Phil, Joe. They are all very much on board. It's the ones that we don't know very much, like the respiratory therapists at night that need more encouragement. And if they need encouragement, we'll come up and we'll sit there and be with you until the patient's extubated. Because the goal is to get them extubated at 4 hours or less. So that means if the patient is still intubated at 2.5 hours, you gotta really be thinking about a plan to get them extubated, okay? What is causing the progression of the patient to slow down? Are they bleeding? Is it bad cardiac output? Is it agitation? What's the reason? How can we manage the reason? Okay? The goal is to extubate them in 4 hours. All right? For a couple years, we were pretty aggressive about extubating patients in the operating room. There is a little bit of a national trend in that regard, but across the board, the nurses did not like that. Okay? it was dangerous. So it got to the point where it was dangerous.
Well, then they'd come in hot and
Yeah.
be biting them, trying
Yep.
to settle them.
Yep.
I like.
Or like, what if they're not stable on, it is.
Okay,
That's
that
why
is
they come back
for
dry.
sure the case with Dane.
If
Oh
he's
yeah,
around.
if he's staying around, there's a problem.
If Dane is in your ear, it's because the patient's bleeding. Okay? McCann, he hangs around a little bit, especially in the patient whose hemodynamics may not be great.
A lot of it.
Okay? He hangs around more than the other two. But
We don't hate it.
No, I understand. But bleeding is the one thing in general to slow us down. Okay, what are some other things? A patient that's been on pump for 6 hours, you know, a cabbage double valve, a redo, a long pump run. There are complications associated with long pump runs, including the kidneys, low cardiac output syndrome, and perfusion injuries to the brain, okay? If a patient is not moving all 4 extremities, shortly after the propofol has been stopped, there's a concern. Okay, that's another phone call. All right, especially if it's focal. Okay, the left side's not moving, the right face is drooping. It gets more difficult when it's cognitive. Well, the patient's not. His extremities are flailing, but he's not following commands. Okay, he's not quite awake enough yet. All right. Let's talk a little bit about fentanyl. We use fentanyl almost 100%. We don't use Dilaudid, we don't use morphine unless they have breakthrough pain. Morphine is a very good pain reliever, but it causes hallucinations, okay? That's the reason we don't use as much morphine. Dilaudid is a better pain medication than fentanyl, but patients like Dilaudid, okay? And it's hard to get them off of it. When they know they're on Dilaudid, they want more Dilaudid. That is not as much the case with fentanyl, okay? Until they've been on it for too long. So we have 2 protocols for fentanyl. We have a 12.5 to 25, and we have a 25 to 50. Depends a little bit on if they've been on pain meds at home, depends on their size, it depends on how much pain we think they're gonna have. But I think in general, across the board, we're using the 25 to 50 in most patients. So we try not to give fentanyl until the patient's extubated. Okay? If your patient is waking up and they're flailing, and especially if they can tell you they hurt, then give a small dose of fentanyl and see if you can get them extubated. Don't blow them away with 50 milligrams or micrograms right off the bat, because they'll be asleep for an hour. And if you're at 2.5 hours, then we're getting too close to the 4-hour extubation time. Okay. This is mostly in the cases that go longer. The shorter the case, the quicker they extubate, the less bleeding they have. Understandable. All right. Air leaks. If there's an air leak, so first of all, we only use 1 bottle. We use Oasis. Okay, I don't even know what the other bottle's called.
Ocean.
Those Ocean bottles suck. Okay? First of all, they make way too much noise. Nobody, you don't use them at all?
We don't.
Even trauma?
No.
Oh.
We did
When did that
once when
change?
we were on back order.
Yeah.
Like there's like a back.
Don't, if we write to pull chest tubes and you see an air leak, don't pull the chest tube. Okay, just wait for us to come back. And yeah, don't pull the chest tube if there's an air leak, okay? In terms of volume, like the next day, the patient's doing well, extubated, all that stuff, and we write to pull chest tubes. If you have a concern about, so first of all, we don't ever pull chest tubes until the patient's been up at least the first time for a walk, okay? That doesn't include when they get out of bed the night of surgery. They gotta be up on their feet, take a walk, lay them back down, and then pull chest tubes if there's an order to pull chest tubes. Okay? If the patient dumps, call us. Okay? Don't pull the chest tube. I can't give you a protocol for all three of us, we pull chest tubes differently, okay? Lee McCann, actually, Dane probably keeps tubes in longer than the rest of the three of us. And then there's one surgeon that pulls chest tubes pretty quickly and pulls them all at the same time. That's me.
That is you.
You said there's one search?
Dane keeps tubes. McCann's in between. Okay, that's probably the best way to put it. If you have a concern about chest tube output, call us. That's the protocol on chest tube output. Okay? If I write an order to pull all the chest tubes and you don't like it, call me. Let me know. Make it my problem, not your problem. Okay? That is really the case with air leaks. If there's an air leak and we didn't pay attention to it and we tell you to pull the tubes, don't pull the tubes, because then we gotta come back up and put a chest tube back in, and that's no fun for anybody. Okay? It's happened. Where we told you to pull tubes, you pulled them, and there was an air leak. And so just make it our problem.
So once they get up and walk and they dump, what
Dump.
would be something to call it? Like what would be a good
So
number?
I think if they put out more than 100 cc's, I'll probably tell you not to pull the chest tubes.
More than 100.
More than 100.
Okay.
Okay?
Because it would be
And
normal
remember-
to have a little bit, right?
Yeah, they're gonna have a
They're gonna
little.
have a
Especially
little
after
bit
a walk,
increase after,
Right.
after dinner.
And then also, when you're concerned about the chest tubes, look at the quality of the fluid. Don't just look at the fluid. If the patient has if the patient's in heart failure and has pulmonary edema, they're going to have increased chest tube output. Especially with less experienced people, I'll get calls, hey, the patient dumped 250 cc's. And then, I'll say, well, what's the fluid? Oh, it's clear. Well, that's good. We want the fluid to come out. That's okay. Yeah. If it's clear, if it's not blood, that's fabulous. Because we don't want to pull the tube out and then have to start doing thoracenteses on them. Yeah. So look at the quality of the fluid too. If it's clear, if you can see through it, that's not excessive bleeding. If there's clots in it, that's concerning. Okay? So sometimes you'll even see us take a pack of 4x4s, clamp the tube, open it up, pour some blood out that's accumulated in the tube, pour it out. What we're looking for is to see if there's clots in it. If there's not clots in it, then it doesn't take very much blood to turn water red, right? Nosebleed, a hemorrhoid, whatever. It doesn't take much blood to turn it pretty red. So if it's not clotting, but then we got to be careful. If they're seriously anticoagulated, then it won't clot either. So you got to be careful. But if it's the next morning and we haven't been concerned about bleeding, then look at the quality of the fluid. If it's thin, pink, rosé, leave the tubes. Don't pull them.
I like that.
That's about as much as I know about wine.
Chest tube output?
White, pink, red, rosé is chest.
There you go. There you go. Respiratory. Call us before you get in trouble. Okay? Call. The better way to put that is call us before the patient gets in trouble. Let us know. We've had a lot of processing and education about communication. And I think all three of the surgeons communicate well, and Ezekiel will communicate well. He's a wonderful person. He's not going to be an ass. He'll do well. The ICU gets our attention way more than the floor does. Okay, we will call you back. If you don't hear from McCann, call me. I will call Mary. I do it at least every month. Okay, at 2 o'clock in the morning, I'll call Mary, and she'll put him on. And he's very apologetic. He's not ignoring the phone. And I think Ezekiel will be the same.